all the concepts covered in this chapter. Any question? Any question? The gas exchange. All right. So the gas exchange, or what we call here the internal and external respiration. So let me open up the slide on here. You mean the gas exchange or the ventilation, Jezebel? You are asking about the gas exchange at the cellular level, or are you asking about the inhalation and exhalation? Just to make sure that I will be answering what you mean. Are you asking about the gas exchange at the cellular level? Inhale, exhale. All right, so this is the ventilation, not gas exchange. All right, so we call this is the ventilation. All right, so in order to allow the ventilation, we need to understand very basic concepts first. First, what are the different pressures that play a role in the ventilation? And the second is where the relationship between the volume and pressure. And the third concept that needs to be clear is how the air gonna be moving from a side with high pressure to a side with lower pressure. So first, what are the different pressures located in the respiratory in the lungs and around the lungs? If I'm looking at one lung here, so this is my airways. And let's say this is my lungs, this balloon on here. Surrounding my lungs, I do have a double layered membrane that has a layer adhering to the wall of the lung from outside and the layer that lines the chest cavity from inside. We call this membrane, it's the pleura. And the pleura, as you see on here, has a visceral layer and a parietal layer. The parietal layer, as we mentioned, it's going to be lining the inside of the chest cavity. So those are my ribs like this. And this is going to be my diaphragm. On the outside of the lungs, the first pressure that we do have is called the atmospheric pressure. This is outside and around the lungs. This is around everything on Earth. What is the atmospheric pressure? Atmospheric pressure is simply the pressure of the air from your body from the surface of your body all the way up until I reach the space. Because all this is occupied with air, and this air has a pressure that is applied on everything in my body. We call this pressure created by the atmospheric air, it's the atmospheric pressure. We consider any pressure in relation to the atmospheric pressure. If it was equal to the atmospheric pressure, we're gonna call it a zero pressure. If the pressure that I'm looking at is equal to the atmospheric pressure, we're gonna consider it zero. It's not actually zero, but it's gonna be considered zero because it's simply gonna be applied on everything. If I am dealing with a pressure lower than the atmospheric pressure, the pressure is gonna be considered a negative pressure. If I'm dealing with a pressure greater than the atmospheric pressure, it's gonna be a positive pressure. So looking at how the air gonna be moving from one side to the other, like anything, air will be traveling from the side with high pressure to the side with low pressure. Very important concept to understand that whenever you increase the volume of a container, this creates a suction force. So the pressure inside drops. So when I increase the size of a container, like this, the pressure inside is going to be decreasing. So there is an inverse relationship between the volume and the pressure. When I increase the volume, the pressure inside drops. And when I have a decrease in the volume, I have an increase in the pressure inside. So like having a balloon. If I have a balloon and I let the balloon, after I inflate it, I let it go. What's gonna happen? The balloon recoils, so I have a reduction in the volume. What happens to the pressure inside? The pressure inside increases. And when the pressure inside increases, the air at high pressure inside the balloon gonna flow to the outside where it has a lower pressure. So the air moves from high pressure to low pressure. Does this make sense so far? What do you think? Jezebel? And Jezebel, what do you think? Does this make sense so far? The relation between volume and pressure and the movement from high pressure to low pressure. Alright, so let's have a closer look at the different pressures in, in the lungs. So I have a pressure inside the lungs. This is my pulmonary pressure or intra-alveolar pressure. As I'm connected to the atmosphere through the airways, the pressure is gonna be almost always equal to the atmospheric pressure. In other words, it's almost always equal to 0 millimeter mercury. This is my intra-alveolar pressure. Almost always equal to the atmospheric pressure. Why? Again, because I'm connected to the outside, and as I'm connected to the outside, air will flow from high pressure. Whenever I have a side with high pressure and the side with lower pressure, the air will flow to equalize the pressure on both sides. So I'm almost always gonna have a pressure equal to the atmospheric pressure, or in other words, a 0 millimeter mercury pressure. On the outside of the lungs, I have the pleura, I have the two layers of the pleura. Always there is a tendency to increase the volume of the space between the two layers of the pleura. What this means? The volume of the space between the two layers of the pleura is trying to increase all the time. Why? Because my chest has a higher tendency, at high tendency to expand with the muscles tone. The chest is trying to move out, and my lungs are like an elastic balloon. They have tendency to recoil. And as we've mentioned, we do have two layers in the pleura. One is attached to the lung, one is attached to the chest wall. So the two layers are trying all the time to move apart. And this is going to be increasing the volume within my pleura. And as I try to increase the volume, if I have an increase in volume, what's going to be my pressure? Remember? If I have an increase in volume, I have a drop in the pressure. So this pressure between the two layers of the pleura, we call it the intrapleural pressure. Is always a negative pressure. It's about negative 4 millimeter mercury. It's negative 4 millimeter mercury. All right, so what's gonna be determining the pressure that will keep this lung inflated? So if I'm telling you I have got a balloon on here and I want to keep this balloon inflated, I have a pressure on the outside that compress it, and I have a pressure on the inside that inflate it. What's simply gonna keep this balloon inflated is the difference between the two pressures, the one on the outside and the one on the inside. If I want to get it inflated, I might have this pressure as 0 and this is a positive pressure, so I am actively pushing air inside the balloon for this balloon to be inflated. Or the reverse. This balloon might be inflated if I do have a negative pressure on the outside and a 0 pressure on the inside. So let's say I have got negative 4, I get 0 on the inside. So the difference in the two pressures is what keeps the balloon here inflated. 0 minus negative 4, it's equal to 4, which is almost the same. If I've got a positive pressure of 4 on here and I have a 0 pressure on the outside, so 4 minus 0 is equal to 4. So what keeps this balloon inflated? It's the difference between the pressure on the inside and the pressure on the outside. We call this pressure is the transpulmonary pressure. So the transpulmonary pressure is simply the difference between the pressure inside and the pressure on the outside. The difference between those two is what's going to be determining whether the lung is inflated or deflated. Again, we call this is the trans pulmonary pressure. So in order for me to allow inflation, for me to allow the air in, what happens? The diaphragm gonna be moving down, it contracts, the ribs gonna be elevated, all this gonna be increasing my volume of the chest. And this volume of the chest when increased, this volume of the chest when increased, what happens to the pressure inside? What do you think? If I have an increase in volume, this results in a decrease in pressure. What is the pressure inside your chest? It's the intrapleural pressure, which is -4. So rather than having a pressure of -4, now it drops to be, instead of -4, it becomes -5. So the transpulmonary pressure that keeps my lungs inflated. So my lungs are inflated, whether I'm inflated or deflated. Anyways, my lungs are going to be inflated. So before I contract the diaphragm, the transpulmonary pressure was 0 minus -4 equals to 4. So this is the pressure that keeps my lungs inflated. After I contract my diaphragm, the transpulmonary pressure becomes 0 minus -5 equals to 5 millimeter mercury. So what happens to the pressure that keeps my lungs inflated? It has increased. So if the pressure that keeps my lungs inflated has increased, what happens to my lungs volume? The volume of the lung in here. Remember, the pressure that keeps your lungs inflated, when it increases, it's going to increase the volume of your lungs. So I have an increase in the volume. And when I have an increase in the volume of the lungs, what's going to happen? What's going to happen to the pressure inside? When I have an increase in the volume, the pressure drops. And what was the pressure, intra-alveolar pressure or pulmonary pressure? It is 0. So when it drops, it becomes -1. And as it drops to -1, remember the lungs here air sacs are connected to the outside, to the atmosphere. On the outside, I have a pressure of 1 millimeter mercury. I'm sorry, pressure of 0 millimeter mercury. This is the atmospheric pressure. And inside now, I have a negative pressure, a -1 pressure. So what happens in this case? Which side has a higher pressure? The atmosphere or your lungs? Which one is greater, 0 or -1? 0 pressure. So the air will flow from high pressure from the 0 to the -1. And this results in inhalation. So I did move the air into my air sacs. It moves from high pressure 0 to low pressure -1. All right, so what happens in order for me to move the air out? So we've learned how to move the air in. So as I keep moving the air in, this pressure goes up to be 0 one more time because the pressure it needs to be equalized by the air movement. All right, so what happens during expiration? So exhalation. So how can I move the air out? What I just need to do is to relax the diaphragm, relax the intercostal muscles, and this is gonna reduce the volume of the chest. And when I reduce the volume of the chest, remember, this will increase the pressure. So the intrapleural pressure, when I was contracting the diaphragm, it was -5. Now I've relaxed the diaphragm, so now it becomes -4 one more time. So the pressure, the transpulmonary pressure that determines whether my lungs is gonna be inflated or deflated has decreased from being a 5 millimeter mercury to become a 4 millimeter mercury. So I have a decrease in the pressure that keeps my lungs inflated. And as a result of this decrease in the transpulmonary pressure, the volume of the lung is going to be decreasing. And as I have a decrease in the volume, what's going to happen to the pressure? Pressure goes up. So my pressure was 0 millimeter mercury. It goes up to 1 millimeter mercury. When the volume decreases, so now I have a pressure of 1 millimeter mercury on the inside of my air sacs, and on the outside I still have a pressure which is atmospheric pressure, 0 millimeter mercury. Which side has a higher pressure now? My lungs. So my lungs have a 1 millimeter mercury, and on the outside I have 0 millimeter mercury. So what happens? Air will flow from inside of my air sacs to the outside. Until when? Until I return back to 0. Does this make sense? Any any other question related to expiration and inhalation? All right, so any other questions related to the respiratory system? Any other questions related to the respiratory system? All right, can we please take like two minutes for break? All right, so just give me 2 minutes and we'll be back. All right, thank you. All right, I'm sorry for this. Just want to double check if you still can hear me and if you still see the blackboard on the screen. All right, thank you. All right, so I want to review another topic with you in the form of in-class activities, which gonna be the lungs volumes and capacities. The amount of air that will be flowing during rest in and out of your lungs in a quiet breathing can be increased. I can breathe in forcefully, getting extra amount of air into my lungs, and I can increase the amount of air that I can breathe out by breathing out maximally, getting all this extra air to the outside of my lungs. But my lungs will still not be deflated. I will still have some air that remains in my lungs. So again, what are the four volumes that we are looking at in here? We're looking at the volume of air that we breathe and out, in, in, out during rest. This is a quiet breathing. What do we call this amount of air that we're breathing in and out in quiet breathing? What do you think? This is your first in-class activity question. Exactly, this is your tidal volume. Tidal volume. And how about the extra amount of air that I can breathe in beyond the tidal volume? What do we call this extra amount of air that we can breathe in beyond the tidal volume? This is my exactly inspiratory reserve volume. So what is the extra amount of air that I can breathe out beyond the tidal volume? I can forcefully move extra amounts of air to the outside by maximal expiration. This is my exactly, thank you so much, my expiratory reserve volume. And would my lungs collapse? Would my lungs collapse after I get this extra amount of air? Or would I still have air inside my lungs? I still have air inside my lungs. What do we call this remaining amount of air that you can't move to the outside? Even after you, even if you're performing the maximal expiration, this is your residual volume. Exactly. We use those different volumes to build the different lungs capacities. The first capacity that we're looking at, it's the maximal capacity that can be held in your lungs. What do we call this capacity in here that I can hold in my lungs? The maximum amount of air that can be held in the lungs. This includes inspiratory reserve volume, the tidal volume, expiratory reserve, and residual volume. All of this is called my total lung capacity. And what do you think we call the amount of air that we can breathe in maximally after a normal expiration? If I'm performing maximal inspiration after normal expiration, after I get the tidal volume out, I breathe maximally in. What do we call this capacity? This is my inspiratory capacity. Inspiratory capacity. And what do you think we call this amount of air that in most of the time it doesn't get exhaled, which includes the expiratory reserve volume as well as the residual volume. Most of the time, this amount of air is not going to be moving to the outside of the lungs. It's kept trapped inside the lungs. So what do we call this amount of air? It's my exactly functional residual capacity. And what do we call the maximum amount of air that I can breathe in and out of my lungs? And this is going to be the amount of air that you can be moving by maximal expiration after maximal inspiration. The maximum amount of air that I can move in and out of my lungs, this is what we've called the vital capacity. And what's forming the vital capacity? It's formed by inspiratory reserve volume, the tidal volume, and the expiratory reserve volume. Any question? Any question here? This is very, very important, a very important topic. Again, on the exam, you have two ways by which you will be addressed those kind of questions. First, I will ask you to identify the volume and the capacity that is marked on the graph. And the other form of questions is for me to ask you to check the value of any of them according to the graph. All right, so let us have a quick review here for the most important diagrams that you should be preparing for your upcoming lab exam. So a very important diagram on here, it's a 5 stars diagram, is going to be showing the upper respiratory tract. Every single marking on this diagram is of great importance. Very, very important diagram. It's a 5 stars diagram, highly important. A 4 stars diagram is showing the upper view of the oropharynx, and I can see the glottis on here, through vocal cords, folds vocal cords, the different cartilages that will be sharing in the formation of the larynx. To the inside, I have my trachea and tracheal rings. Another 4 stars diagram is going to be showing the lower respiratory tract, showing the trachea, the main bronchi, the secondary bronchi, and the tertiary bronchi. So, main bronchi or primary bronchi, those are the right and left primary bronchi on here. The lobar bronchi or the secondary bronchi, those are the main branches from the main bronchi, and the segmental bronchi, those are the smaller branches to the curve. Highly important, it's a 4 stars diagram. A 5 stars diagram is showing the transverse section of the chest cavity along with the internal thoracic organs, the heart and lungs, along with the main vessels. Highly important, highly important. Every single marking on here is highly important for us to be able to identify. And of course, the lungs, volumes, and capacities is highly, highly, highly important. Lungs, volumes, and capacities are highly important for us. So I will rate those two tables on here 10 stars each. This is a must be on your test. Lungs, volumes, and capacities here are highly important. Those are must be on your test. Remember, we do also have blood related diagrams that are covered in this upcoming lab exam, and the essay question is for the erythroblastosis fetalis, as you did watch in the video recordings. So looking at the important diagrams related to the blood, you need first of all to be able to identify the various blood cells under the microscope. So if I'm looking at a segmented nucleus with purple and pinkish cytoplasmic granules, is this gonna be the neutrophil? If I see reddish cytoplasmic granules everywhere within the cell cytoplasm, this is a eosinophil. Remember, the eosinophils will have acidophilic granules which are stained red. If I'm looking at the cells that has bluish or purple cytoplasmic granules, those are going to be my basophilic granules, and the cells here that we're looking at are the basophils. Basophils. If I'm looking at a white blood cells, it has a dark large nucleus that occupies around 80% of the size of the cell. This is a highly active immune cell, a highly active white blood cell. We call this is my lymphocyte. Lymphocyte. Another type of white blood cells that we're looking at in here, it's a white blood cell that has a kidney-shaped nucleus. White blood cell that has a kidney-shaped nucleus. This is my monocyte. And remember, the monocytes are the precursor cells for the tissue macrophages. Monocytes migrate from the bloodstream to relocate within your tissues of the organs to become the tissue macrophages. Those are again my monocytes, and the special characteristic here that allows us to identify them is this kidney-shaped nucleus. A very important diagram also is going to be the diagram showing the reaction when testing the blood type. Remember, if I have this agglutination reaction, the cells have been clustered together like what you see on here. So this means I have a reaction between the antigen and the antibody. So if the blood drop I'm testing had a reaction with both anti-A and anti-B, this means what for me? This means that the blood type I'm testing is containing antigen A for it to react with anti-A and antigen B for it to react with anti-B. So what is the blood type that contains both antigen A and antigen B on the surface of its blood cells? It's going to be my blood type AB. What if I have a reaction only with anti-A? If I have a reaction only with anti-A, this means I have only antigen A on the surface of my cells. If I only have antigen A on the surface of my cells, what is the blood type? Blood type A. What if I have a reaction only with anti-B antibodies and not with anti-A? So this means that I have only antigen B on the surface of my red blood cells, and this makes me a blood group type B. What if I don't see any agglutination reaction with neither anti-A or anti-B? If I don't have an agglutination reaction either with anti-A or anti-B, this tells me that the blood cells I'm testing do not have neither antigen A or antigen B on the outer surface. So if I don't have antigen A and antigen B on the surface of my red blood cells, this means I'm a blood group type O. This is a very, very, very important diagram. It's a 5 stars diagram. Just pay attention to where is anti-A and anti-B on the test, because I might be changing the position here just to test your knowledge. The essay question, as I mentioned earlier, was the erythroblastosis fetalis. Does any of you has a problem with the erythroblastosis fetalis? Any problem with erythroblastosis fetalis? Question related to the erythroblastosis fetalis. Anybody is not sure what to write down in this essay question? All right, so what we should be covering in our response for this question. So you need to describe when this happens. So you're gonna need to tell me that the mother needs to be an RH negative and her baby is RH positive. This is very important. During pregnancy of the first child, the mother's immune system doesn't get exposed to the RH antigen, so the mother doesn't have anti-D antibodies. This is very important to state that the first exposure to the D antigen is going to be taking place during labor. So during labor, some of the blood cells of the baby going to be passed into the mother's circulation, exposing the mother's immune system to the antigen D, and this is going to result in a lifelong production of antibodies against antigen D or anti-D antibodies. So the problem is going to happen with any other pregnancy. During any later pregnancy, if the baby is Rh positive, the mother now is capable to produce anti-D antibodies, which are IgG type, that can cross through the placenta. So anti-D antibodies will cause red blood cell destruction for the baby, causing jaundice, multiple organ failure, and may result in stillbirth, or the baby dies shortly after birth. How to prevent it? We give a raw gram shot that contains anti-D antibodies shot to any mother who is Rh negative shortly after labor and during the late month of pregnancy, just to give her a coverage. So what we're trying to do, we're trying to prevent any exposure of the mother's immune system to any of her children's RBCs. So the program shot, this contains anti-D antibodies, and the main purpose here is to attack the baby red blood cells that might be traveling to the mother's circulation before they get exposed to the mother's immune system. All right? Does this make sense? All right. All right, so this is pretty much everything I wanted to discuss with you today. Thank you so much for making it to the meeting, and we'll see you all next week. Have a good rest of your day. If you please can write down your name in the chatting box. If you still have any question, please stay connected. If you still have any question,
I have a
please
question.
remain connected.
How many questions we'll have to answer? The essay questions, just one or two?
So how many questions? You need
Yeah, for
to tell me the risk factors. So what are the risk factors? With the mother, it's she is Rh negative. The father is Rh positive, and so the babies are Rh positive. This is one thing. How this takes place once the mother, the immune system gets exposed to the baby red blood cells that contains the antigen D. So exposure.